Thank you all for joining GMN's new monthly webinar series, GM Insights, Expert Clinical Insights in Dementia Care for Your Patients. Today we have Dr. Gabriela Cohen presenting, and she is actually the activity director for this new series. So we are excited to have her. Dr. Cohen is board certified in internal medicine and geriatrics. She completed her training at NYU and worked extensively in a memory clinic in her home country, doing clinical dementia care and research on Alzheimer's and related dementia before joining the Division of Geriatrics at Emory, where she now works at the geriatric clinic at Grady Hospital. Before I turn it over to Dr. Cohen, I wanted to remind everybody to please fill out the evaluation survey at the end of the presentation to receive your CME credits. Dr. Cohen, welcome, and thank you for joining us today.
Thank you so much. Thank you for coming here. I want to start my presentation. So first, do you want to speak about this, Dr. Johnson?
We did.
Yes.
Go ahead.
Yes. So this is a disclosure statement for Dr. Cohen. She has no significant disclosures. This is an activity that's certified for CME under Dr. Cohen's leadership as the course director. And so you can get 0.5 CME for participating in this event. Really glad to have you here. My name is Ted Johnson, and I have been working in the primary care education core of Georgia MemoryNet since the program's inception. So glad to have Dr. Cohen here. And I know what she's going to talk about is going to be of great interest. And it just speaks to this fact that when you see patient charts, sometimes you don't know everything that you might need to know in a shorthand way about the patient. So Dr. Cohen's going to talk about accurate diagnosis and clinical stage as it relates to dementia and how that helps you get a better understanding of what your overall care of comorbidities might be. So back to you, Dr. Cohen. I'll interrupt you every once in a while and put some things in the chat box. And so, but the floor is yours.
Great. Okay. Thank you for being here. Okay. So today we are going to be, as Dr. Johnson said, talking a little about how to use the assessment tools for function and cognition, how to order the right imaging study. And we're going to do this over two clinical cases, actually, so it's more interactive and more dynamic. Good. And the whole idea is to teach and show how staging in dementia is really important and how we personalize and we tailor interventions based on the stage of the dementia. Okay, so we're going to be presenting two cases, two patients with the same main complaint, memory loss and a 10-pound weight loss for the last 6 months. So a little bit about weight loss, and this is not talk about geriatrics, but just to remind a little bit what you do when you have an elderly patient with weight loss. We think about medical causes like endocrinology causes, diabetes, uncontrolled diabetes, thyroid disease, hypercalcemia, kidney failure, heart failure, COPD, GI disease, celiac disease, malabsorption, swallowing difficulties. We also really discuss and we consider if these are psychological causes that could be caused the weight loss. And here we try to do screening for depression, frailty, and this one is really important, the lack of social support and difficulties in performing instrumental activities of daily living. This one is a big one, and severe dementia. And here on top in red, last but not least, is medications, and many medications have adverse reactions. And regarding dementia, it's nice to remember that cholinesterase inhibitors, really like donepezil, galantamine, rivaroxaban, really produce a decrease in body weight. So we always have to remember a patient who has dementia and is on one of these medicines, dementia-specific medicines, that if the patient lost weight after we started the donepezil, we had to remember that it could be the adverse reaction from the medication. So keep in mind this slide, and let's go back to the first case. So the first case is, we have two cases, Mr. A and Mr. C. They both have the same age, 78. They both have memory problems, and they both have exactly the same comorbidity. Past medical history of type 2 diabetes, gout in remission, hypertension, osteoarthritis, and diastolic dysfunction. And the main complaint of this visit, as I said before, is weight loss of more than 10 pounds in the last 6 months. For us geriatricians, this is a significant weight loss, and unintentional weight loss of more than 10 pounds is something that we really want to study and consider and have a thorough evaluation. So going back to Mr. A, that's the first patient, he was diagnosed with minimal cognitive impairment, the amnestic plus side, and I'm going to describe very soon what it means. 2 years ago, he lives by himself, and he actually comes to the clinic to see me, and he is coming with his son. And this is interesting that the son, this is the main verbatim chief complaint of the transcribed from the son, and he says, and I'm going to read, I'm very worried, he's not eating much, and he's making some mistakes with his medications. This is a very common initial complaint. And he is sometimes anxious and irritable, and he is still driving. So in one sentence, we have a really understanding of this patient's problem. And what the patient says, and this is really interesting, he says, I'm doing okay, and I don't know why he worries so much. So at that visit, we do a cognitive test, and we are using here the SLAM, which is a cognitive test similar to the mini-mental, but a little harder to do. And it really explores memory, language, visuospatial skills, a little about executive function. And this patient in this visit scored 20 out of 30. So the cutoff for this test really depends on the educational level, but 20 is definitely a little low. So regarding— Can I just
offer one comment about the SLUMS? And so SLUMS is St. Louis University mental state exam. And so I'm going to put a link to this resource in the chat box for those of you who have some practice time over at the VA. The VA very quickly abandoned the Fulstein mini mental state examination because of the $1 surcharge per test administration. The SLUMS was the MMSE was a great test that we used for years and years and years. And then all of a sudden it became proprietary. The St. Louis University mental status exam was developed at the St. Louis University VA Geriatric Research Education Center and is embedded in a lot of other materials, but folks might not have the opportunity to use it as often. And I agree with Dr. Cohen that it is slightly harder than the MMSE and has a different scoring range, but is scored out of 30. Thanks, Dr. Cohen.
Excellent. So this is the MRI, and I include a coronal slide where you could actually, and I'm marking here the part of the medial temporal lobe that were really interesting. This is a hippocampus area. And with this yellow arrow, I'm showing that this patient had mild hippocampal atrophy, not really severe. And it's interesting because sometimes we don't really have coronal cuts on the MRI. And if you only have an Asian MRI, this is the blue arrow is showing where the hippocampus area is. This little black area is where the choroidal fissure is. And again, this patient has mild hippocampus atrophy. Here we have a different sequence to see anterior posterior cuts where we see that this patient had a really high burden of white matter hyperintensity disease, and we stage this from stage 1 to stage 3. And when these lesions are big, white, confluent, we call this severe or stage 3. And we use different scales for this. And we want to have more lectures down the road on how to diagnose dementia and about neuroimaging. Good. So a little bit about this. So how we diagnose dementia, the most important piece of information is the interview with the patient and a relative member who really knows the patient. And in this case, is the son who is giving us all this very rich information. And the second step is know exactly how the patient is performing activities of daily living. And that's how we make the most important part of the diagnosis. Of course, we do some cognitive tests, and we usually use a screening test. And if the screening test is positive, then we use some confirmatory tests. And in this case, I presented the SLAM, which is a screening test, but also in this patient, I also did a mini-com, which we have a really interesting lecture last month. And once you have the cognitive test, we really want to rule out secondary causes that could mimic dementia, but it could be any other disease, for example, hypothyroidism, occult depression. And for that, we order usually And neuroimaging, ideally, we want to do an MRI, if possible, at the diagnosis, which of course is more useful if the patient is less than 65 years of age, if he had focal neurodeficit on presentation, if he had abrupt onset or rapid decline, if he had predisposing conditions, atypical presentations, and definitely for differential diagnosis. So ideally, if we can, we get an MRI. We don't really need contrast unless we are suspecting metastatic cancer or vasculitis or an encephalopathy, but usually we just do an MRI without contrast, and we really want to look very careful on the axial, sagittal, and the coronal cut, as I showed before, for seeing hippocampus atrophy is very, very useful. So a little to remember, and this is a slide original when we to describe the biomarkers on Alzheimer's disease, and we're going to have more lectures about this. But you could go from a cognitive normal performance to have this condition, like this patient was having before, we call minimal cognitive impairment, and some of these guys will progress to dementia. And as you see the different curves, different things are happening in the brain before we have the first symptoms of the disease. So at the beginning, we have amyloid deposits, then we have tau mediated inflammation. Then we had some atrophy where, for example, on a structural MRI, we can see the atrophy. And after that, we see the memory problems and the clinical function. So this is nice to remember that the pathophysiology of Alzheimer's starts at least 20 years before the presentation of the disease. And going back to our patient, he was diagnosed with minimal cognitive impairment 2 years ago. At that time, he had a SLAMS of 27. And remember that I say that now the patient is scoring 20. So he lost 7 points in the last 2 years. So there is definitely some progression. At that time, he had a normal clock drawing test, and I'm showing it here. And we did a cognitive test, a full cognitive test at that time. And he did have significant problems with episodic memory, executive function, a little bit with verbal fluency, and the rest of the cognitive domains were normal. But at that time, 2 years ago, his functionality was totally intact. And now the patient is presented with some difficulties in EADL. So here is a scale that we use, the basics activities of daily living. We usually use this very easy 6-point scale. And this is the CATS activities, the CAT scale for the activities of daily living. And then we do the instrumental activities of daily living. And in this patient in particular, he is totally independent in all the basic 6 activities of daily living, but he is starting to have some problems with bills and finances, with preparing his food, and maybe shopping for groceries, maybe for transportation. He's still driving, but we don't really know how he is driving, and some problems with medication. So overall, I say now I could say that the scale was 6 out of 8, but maybe he is even a little lower. So there's definitely some progression. The patient was independent before, and now he is struggling with EADLs. And this is how we stage dementia. We use this scale, which is called the Clinical Dementia Rating Score. We consider 6 different domains, which are memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. So after we interview the patient, after we spoke with the family member, and after we examined the patient, we really had to decide if the patient has impairment, if these impairments are mild, moderate, or severe for all these different domains. And in this case, the patient has mild dementia, which corresponds to the CDR of 1. And definitely the patient crossed this line, he's having problems with EADLs, and now he's having dementia. So we have a patient with mild dementia, living alone, and losing weight. And a little bit to remember the progression. So we said that the patient before was here with MCI, and now he progressed over 2-3 years, and now he had mild dementia. Good. So let's go to the second case. So the second case is different. It's Mr. A. and he is coming with his wife, and the wife says he is progressing, he is declining, he is falling, he needs help with everything, and I'm very tired. So again, with this first sentence, we know that the patient has definite difficulties in EADLs and probably basics ADLs, and he is having frequent falls. And we also have some input on how the main caregiver is doing, and you see that she's very stressed and very tired. And what the patient says, and this is interesting, there is this discordance between what the family member says and what the patient says. The patient says, I don't want to take that many pills. And that happens a lot in our patients. They have polypharmacy, they're taking many pills, and his insight is that he doesn't want to take that many pills. In this case, he was diagnosed with mixed dementia 7 years ago. And when we do the cognitive test in the office at this time, the patient is having trouble with temporal orientation. The slumps, the same scale that we spoke about before, he is scoring less than 10. So this is really severe decrease. And we do a mini cog, and he is scoring he's not scoring anything, he's scoring 0. So this is the clock that he actually draws. You can see that he is missing, actually he put the 12 numbers, but they are not in the correct orientation. And he was not able to set up the time either. So this is a 0 out of 2. And then he couldn't remember any of the 3 words. That's why we say it's a 0 out of 5. So his symptoms started at least 7 years ago, but he had his first cognitive evaluation only 2 years ago. And at that time, he had a mini mental of 21, and he scored 19 in the SLAM. So there's really progression. The same scale that we used 2 years ago, he actually lost 9 points in 2 years. And that's kind of, usually we say that losing 5 points on the mini-cog every year is the normal progression of Alzheimer's. With the SLAM, I'm not sure it's so well validated how much is normal, how much decline is normal, but this patient definitely has some progression. Good. And this is his MRI, and this is again a coronal picture to see really and to focus on this area of medial temporal. And we see there is a lot of atrophy, much more than with the previous patient, of the hippocampus, which is this structure that I'm signaling here, and also of the cortex that is just below the hippocampus. This is the entorhinal cortex. So this patient has severe hippocampal atrophy. And on the axial slide, we see that he has some white matter hyperintensities, but they are really much, they are bigger, they're not normal, and he has some lesions, and we said he probably has moderate microvascular disease, and we stage this as a stage 2. Some of the lesions are a little big, but then a little confluent, but not really big. So this is moderate microvascular disease. Regarding his functioning, he's really struggling with everything. He is basically dependent on almost all his basics ADL. He's able to feed by himself, and he's definitely dependent on all his EADLs. He is taking all these medications, and this is a total of 11 different medicines: donepezil and memantine for his memory, and amlodipine, losartan, furosemide, spironolactone for his blood pressure, and then aspirin for primary prevention, which is questionable, atorvastatin, glipizide, metformin, and allopurinol. So remember that the main complaint of the patient is that he didn't want to take that many pills, and he has, as I'm going to show you, severe dementia. So going back again to the same scale, in this case, the patient has severe dementia. This is a CDR of 3, that's how we stage it. And again, he is in this part of the chart, and at this time, he is having swallowing problems, more motor problems, definitely mobility issues, and his cognitive status is very compromised. So he has severe dementia. Going back to the first slide, so we really think that the first patient, probably he was losing weight because he had lack of social support. He converted from mild cognitive impairment to mild dementia, and he had no supervision and no help with some of his instrumental activities of daily living. In this second patient, I really think he's having swallowing difficulties, and that's the main reason with severe dementia why he is losing weight. And a little bit, just 1 minute of what we do. So we first stage the patient, and based on the staging, we offer different recommendations. For the first patient with mild dementia, disclosing the diagnosis of dementia, giving education to the caregiver, offering and prescribing supervision in EADLs, managing his behavioral symptoms, talking about priorities and preferences, and of course, talking about counseling during driving, because he was driving by himself. And he definitely needs some dementia care services, like probably he needs supervision with buying groceries and with cooking, so he stopped losing weight, and with medication too. For the second patient who has severe dementia, the recommendations are really different. We're really going to talk about management and managing his comorbidity in this patient with severe dementia. Can we stop some medicines? Does he need 11 medicines? Does he need such a strict blood pressure control in someone with severe dementia? We're definitely going to give a lot of education and recommendations regarding swallowing problems, because we don't want this patient to keep on losing weight. And we're definitely going to offer some support for the caregiver, because we identified that the wife really had caregiving burden. Again, talk about priorities and preferences, and in this case, about advance directives is really important. So I think I'm going to stop here and we can start the discussion.
Thanks so much, Dr. Cohen. Really appreciate it. I'm looking and watching the chat to see if there are any questions in the chat. If you feel like you want to offer your question just in the room, feel free to take yourself off mute and go ahead and ask your question. Dr. Cohen, thanks for providing your email right here. If you
have
if you
any
don't mind,
questions, of course, you could email me. Okay. So I see that you put here where we can find the CDR and the SLAM. This is really useful information. And do we have any questions?
I wanted to start with one question, and that's I put on the screen just a copy of the mini mental state examination as well as the slums. You were talking about this earlier. I would draw your attention to the fact that there's clock drawing in the slums, but not in the mini mental state exam, that you have this story recall that is harder than most elements on the mini mental state examination. And so thinking about your experience of using the slums, if somebody scores 5 points on the slums, what are they getting correct? Meaning, what are the things that are most preserved?
Well, that's a very good question. So first, the mini mental, let's just sum up very quickly. It gives a lot of points of orientation. That's 10 points versus only 3 points on the SLAM. So the mini mental is, in the mini mental, one of the most common critiques to the mini mental is that executive function is probably not represented, and language is very, very basic. We just ask the patient to name a pencil and just 2 very common objects. On the SLAM, the language part is much more detailed because there is a test of fluency. So we ask patients to give animals in 1 minute, and that's a very good fluency test. It's definitely much better on executive function, and delayed memory is really much better because we have 2 different tests. We have the 5 objects, which is just learning by memory and a list of words, and then we have the story. So I would say that testing memory and delayed memory is much stronger on the SLAM. So if they score 5, usually at this stage, they don't know how to do the clock, and they definitely have some temporal problems, but maybe we could give some points because they may be able to say 5 to 9 animals, for example, and usually recognizing the figures is not so hard. So in my experience, the points come from there, from the figures, and probably and some of the attention tests are not that hard either.
Thanks so much for that, Dr. Cohen. Could you go back to your slide that showed the CDR in your presentation? We had a question in the chat about that.
Yes. Sorry. Yeah, which slide?
Keep going. Keep going. Keep going. Keep going. Keep going. I'll tell you which slide number it is. I'm so sorry for doing that to you. It's slide 13.
13. Okay. Yeah, the CDR. Mm-hmm.
Yeah. Could you talk a little bit more about, are we Are we adding up these boxes? In your example here, all of them were directly aligned.
So what you do is, it's a very good question. And thank you for asking. I'm sorry, I kind of jumped kind of quickly. So what you do is you have an interview and you see, for example, on orientation, because you do the SLAM, so you really know the orientation of the person, and you interview the patient and you really know how this patient is functioning because you do the functional scales. So after that, the physician or the provider really has to find out, and you go row by row, and you, for example, you think about memory. This last patient, how bad is his memory? Is it severe memory loss, or is it so severe that only some fragments remain? And you go row by row. For example, in this patient, we could say that he's stage 3 on memory, and then you go to the second domain and orientation. Again, he was a stage 3, only oriented to person, and then judgment and sober problems. And imagine that this patient is scoring 2 on this one. So maybe you have some of these domains that are a 2 and some are a 3. So depending on how many you have, and usually this is interesting, the memory rows wins. And there are some algorithms that you could download for free, and you put one by one, and it tells you exactly what the final number is. But sometimes we're not sure if it's moderate or severe, and we go and we use the algorithm. But so you go domain by domain. But usually there is like a pattern that everything kind of goes together, and that's how you can stage it. In the first patient, it really was mild dementia.
Got it. That's very helpful. And just wanted to point out that, let's see, there we go. There are certain iPhone apps that you could download to actually get a copy of the CDR and begin to fill it out there, as well as a PDF in the box. And I believe we have 2 questions. Let's take the Laura Flatt's question first. Go back 1 slide, please. That would be slide 12. Gosh, I'm so sorry. Laura, it's that one. Thank you, the function one. Laura, do you want to come on and just ask your question, please? Got it. It may just have been a request to show that slide. Leslie Miller had a question about the utility of MoCA versus slums. Perhaps you could talk about when and why you use each one, how long they take to administer, questions like that. Thanks.
Well, it's actually an interesting question. So what we have to remember is that the MoCA, the SLAM, the mini-mental, and the mini-COP, they are all screening tests. So you're not really diagnosing dementia just on one test, but they're very useful to do a screening test, and they're very useful, in my opinion, to follow the patient through the years. So if they decide to do MoCA at the beginning, it's nice to keep on doing the MoCA so you really see the progression. So I think that from all these 4 screening tests, and also the number 5 is Addenbrooke, that is also really hard. But from all these screening tests, some of them are easier and some are that they're not that easy, and they all really depend heavily on education. So at least you need someone to complete at least elementary school or 6 grades of elementary school to be able to do it. But you could do the MoCA, but then if you want to confirm dementia, you had to do some other tests. So again, this is a screening test. This is a MoCA. I would say that MoCA versus SLAM, you do have a lot more of, you really test the executive function much better and the attention. And if you want, I don't know if you've had time, Ted, I can go domain by domain and talk about the MoCA, or as you want. I don't know how much more time you have. So very quickly.
We're coming up on the end, but go ahead and finish up with that. That would be great.
So the MoCA, this is part of the trail making B test that is usually part of a full cognitive assessment. So basically you first teach them what you want, but you want them to be able to link number 1 with letter A, number 2 with letter B. And really it's a time test. You see how many seconds it takes for them to do this. So this is a lot about attention, a little of visuospatial, but a lot of executive function. Then you ask them to copy this, just copy. Then you ask 3 questions about naming, and these 3 animals are really hard. On the mini-mental, we just ask them to name a pencil, which is a common, it's a very commonly used noun. But here, lion, rhino, and camel, these are 3 words that we don't really use it that much. So this is a really good test to pick up anomalies. That means when you don't remember the exactly name of an object, you recognize the object, but we don't know how to name it. Then you do a memory test, which is, again, is similar to the SLAM. It's just a list of different words. Then you do a little of attention, language, abstraction, and delay recall. So I would say that maybe the SLAM is a little better on delay memory, but this one is harder on executive function and on the language.
Dr. Cohen, I want to thank you so much for a fabulous talk. I really appreciate all the folks who dialed in to watch the talk. It was recorded and look forward to having that. And Lori, I'm going to turn it back over to you because you're going to take us out.
Thank you so much. Can everyone see my screen with the evaluation survey?
Yes.
Okay, great. All right, thank you for joining, and please fill out this survey, and we look forward to you coming again next month, the third Wednesday of